Добрый день, участники.
Good afternoon, dear attendees to the section number 17. We are supposed to discuss an issue on vaccination, and national calendars for vaccinations are in place. And we start forgetting about various infections, but it will be really worthwhile to follow presentations on the prevention of measles, poliomyelitis, and the COVID-19 infection. And the coronavirus was a new challenge for us for 2020. But thanks to measles, when it started being exposed 2 years ago, so we were prepared for vaccination, especially at the level of the Republic of Belarus. And we have managed to talk about the preventive measures and started some anti-pandemic actions. And we have Patrick O'Connor on the online mode, and he is the one to talk about vaccines, and he is going to speak about the elimination and control over Europe for WHO. The floor is yours.
Не слышно.
Sorry, we can't hear you. Just one minute, we will tune you in. Can you hear us? Can you hear us? Can you hear us? Okay, you may start talking.
Да, вас слышно, да. Все окей, слышно.
It's okay? Okay. All right, thanks. So thank you very much, and I really appreciate the opportunity to be able to give you on vaccine prevention. I'm from the WHO regional office based in Copenhagen, Denmark, is where I'm broadcasting from today. And I really appreciate being able to sort of set the stage for this discussion. And I do have a couple of slides, so let me see if I can upload those. Yes. And I believe, can you see the slides? Okay, so I sit in the Vaccine Preventable Disease and Immunization Flagship Program. And the Regional Technical Officer for Disease Control and Elimination. And so I focus mostly on polio eradication efforts, making sure that the region remains polio free, and the measles and rubella elimination efforts. I think those programs in particular provide a very good example of how WHO provides coordination efforts in the region, as well as provides technical guidance where needed, and has brought together the region to set goals for the region that are in line with goals. And so just to familiarize with the WHO European region, you can see on the map here, we have a cartoon of the region. We have one of the largest WHO regions with 50 states and a population approximately of 1 billion people. The regional office is headquartered in Copenhagen, and you can see that we have approximately 31 country offices, WHO country reps, or other heads of country providing sort of direct country support. And so I thought I would start with what we're currently looking at, which is the European Vaccine Action Plan, which was from 2015 to 2020. And since we're in 2021, we're using this as the opportunity to evaluate how well we've done with this Vaccine Action Plan that was agreed to in the regional committee meeting in 2014. And provide some guidance on specific disease control goals. And so this slide is from the midterm review, which was conducted in 2018, and outlines the polio-free status, which thankfully was on track, the elimination of measles and rubella, which at that point had not been achieved, and the control of hepatitis B, which is still currently in the validation process. And once the evaluation is done to sort of look at the end of 2020, we'll be able to sort of provide more feedback. So I'll focus on the polio and rubella in particular in this presentation. So as we come to the end of this particular European Vaccine Action Plan, we have the next iteration of sort of the global program, which is the Immunization 2030, which is a strategic plan. And so we are currently here at the regional office in the process of coming up with the EIA 2030, which is the European Immunization Agenda 2030. And so we are looking at how we're going to be able to incorporate those elimination and eradication goals that are appropriate for the European region. So I'll start with polio. And here is the polio-free status for 2019. As many of you probably know, there is an independent group of experts called the Regional Certification Commission for Polio Eradication. They meet on an annual basis, and the last time they met was in September of 2020 to review the 2019 data. And based on the reports that are submitted by member states, we were able to confirm remain polio-free and that there were no polio-infected countries for 2019. So this is in line with the work that the region is doing, that member states are doing in order to ensure that we remain a polio-free region until the global program can declare the world polio-free. We have a couple of countries in the Eastern Mediterranean region, particularly in Afghanistan and Pakistan, that are still have wild virus circulating. And so I think a lot of efforts are being made to ensure that that program moves ahead and that those countries can achieve the polio-free status. So along with reviewing the polio-free status, the Regional Certification Commission also evaluates risk. And so they look at a lot of things, including immunization coverage, surveillance of polioviruses. And so they come up with this risk map. And so what it does is it highlights those countries that may be in danger of circulation after importation or the emergence of a vaccine-derived poliovirus. And so the commission ranks the countries from low risk to intermediate risk to high risk. And it's a variety of factors that go into this calculation, but it helps us to sort of evaluate where us at the regional office need to provide additional technical assistance or to provide different guidance on how to implement certain programs to mitigate risk. I will highlight that since the Commission met in September of 2020, we have had an importation into Tajikistan from Afghanistan for the virus that has origins in Pakistan. It's a vaccine-derived polio virus, which is not the same as a wild polio virus, but still requires interventions and activities. And so currently we're providing support to Tajikistan along with the global partnerships for polio eradication to conduct campaigns in May and June to make sure that we respond to this appropriately and that we've protected the rest of the region. And Tajikistan has done a fantastic job in preparing for this campaign with the new and improved oral polio vaccines. And so I think this is something to highlight that, that despite the region being polio-free, that we are at danger of importations from our neighbors at any time. And so continuing those efforts for high vaccination coverage and good surveillance are quite important. So to give a little snapshot of the verification of measles and rubella elimination, you can see here that the region as a whole, all 53 member states taken in consideration, have very high coverage for the first and second dose of measles and rubella containing vaccine. And we're one of the only regions in which every country has an immunization schedule that includes both measles and rubella, and all countries in the region are using measles, mumps, and rubella, or measles, mumps, rubella, and varicella combination. Provides a real great coverage for the region. I mean, despite that high coverage, you can see that in 2019, we had a lot of measles cases in the region. And I think it just highlights the issues that we have with some of the subnational coverage or pockets of unimmunized children and adults. And so there were a lot of efforts to combat that through supplementary immunization activities and to sort of react to those measles cases. And so I think this is really great, a great opportunity for us as we move into 2021 to hit where those gaps are and try to respond to them. So like polio, we have a verification commission that looks at the measles and rubella status of the region, and evaluations were created in 2011 and have been evaluating the status of the region since 2012. They met for the last time in December to review the December of 2020 to review the 2019 data. And so here's a graphic showing the number of countries that have been eliminated or that have been able to interrupt. And you can see that in 2019, because of those large outbreaks that were in 2018 and 2019, that we've had a couple of countries that reestablished transmission and were unable to sort of stop those large outbreaks before the evaluation of the commission. And so, and you can also see that we did in 2019 have countries that were unable to submit documentation in 2020, and that was mostly because of the coronavirus outbreaks. Many of the programs, the people that are doing measles and rubella were also tasked to work on coronavirus response and now vaccination. So we're hoping that when we evaluate the 2020, that we will be able to sort of review those countries that were unable to submit and complete this graphic. If we look at rubella, you can see that there's been tremendous progress in the region. And I think that we are extremely close to being able to verify the status of rubella being eliminated in the entire region. We have a couple of countries that didn't submit because of coronavirus. And then we have a couple of countries that we've initiated a new program, particularly for rubella, to make sure that it gets the much needed review with some retrospective reviews of countries and to make sure that the data reflects the actual situation in the countries. And so I'm fairly confident that we do not have ongoing widespread transmission of rubella in the region. And so we're just working very hard to make sure that documentation is complete and we can submit to the commission for them to review. So I'm quite hopeful that this year we'll be able to complete the verification of rubella. And so that would be a great accomplishment for the efforts of the member states, and it would be the second WHO region after the Americas to verify the region as being rubella eliminated. And so I think that would be something quite tremendous for us to be able to document and then to obviously celebrate. So, looking at WHO, and particularly in the European region, one of the big, I think, advantages that WHO has is that it provides an opportunity to convene member states. So WHO has this convening power to bring together the members of the region, and in previous regional committees, the member states have been committed to maintaining the region's polio-free status, and then also several times to working to achieve measles and rubella elimination, and then controlling hepatitis B. And so based on that commitment from member states, here at the regional office, we really are committed to coordinating and supporting technical support to achieve those goals, and looking at how we can do that at the national levels or sub-regional levels by grouping together countries with common interests. We have in the past, particularly with the polio program, used sort of Central Asia and the Caucasus as a block of countries to coordinate campaigns within the European region, and then also with our neighbors to the south in the Eastern Mediterranean region. And then we've also are able to mobilize global and regional partners, different mechanisms. And then, of course, here at the regional office, we support those independent advisory groups and commissions to provide guidance through the European Technical Advisory Group or through the Polio Regional Certification Commission and the Measles and Rubella Verification Commissions. And so that's just a very short snapshot of where the region is as far as polio, measles, and rubella, and then also some of the sort of support that we provide and guidance that we're able to provide here from the regional office. So I really appreciate this opportunity. I wish I was able to join you in person, but I'm happy that I was able to connect via this forum. So thank you very much.
Thank you very much, Patrick O'Connor. We have achieved a lot in terms of polio status and measles and rubella combating. We will prevent hepatitis B, but as you have mentioned, we should keep track on it, and we will keep track on it in order to confirm the elimination of measles, rubella, and polio. Thank you very much for your presentation. Our following presentation is adequate epidemiological surveillance over measles and rubella. Olga Tsvirkun, the head of the epidemiological department of Moscow Scientific Institution of Epidemiology, of Rospotrebnadzor of the Russian Federation. Olga, the floor is yours. Good afternoon, dear colleagues. Let me express my gratitude to the organizers of this conference for the chance to present the results. It is common knowledge that the system of managing the epidemiological process includes epidemiological surveillance, and its role is crucial. Organization, flexibility, and timely response and fullness of epidemiological surveillance determines the substantiated decisions of management, and also epidemiological surveillance determines the effective activities. The key goal of epidemiological surveillance is to minimize the uncertainties while making the decisions. It is achievable by organizing monitoring of morbidity, monitoring of circulation of the pathogens, and monitoring of population immunity. This regimen is widespread for all the infections. It is applicable for epidemiological surveillance. In 2002, the European Regional Bureau of the WHO set the goal of elimination of measles and rubella by 2010. The RF devised its own program aimed at elimination of the measles infection. This regimen of epidemiological surveillance was not satisfactory, and we had to arrange epidemiological surveillance based on integration and laboratory confirmation, and accounting for all the cases which are suspected cases of measles. In 2002-2003, we organized national scientific and methodological centers for measles surveillance. There were also 10 regional centers. The laboratory network for verification of each case was created. Monitoring of molecular and genical typing of circulating strains of measles was organized. We also launched individual accountability of morbidity. For this reason, we devised additional report forms on a monthly basis for each age group and history of vaccination. And there was also the report for epidemiological investigation for suspected cases of measles. These documents played the key role in understanding of changes in the epidemiological process of measles. Individual accountability of morbidity is not that new for us. It was first introduced at the federal level, because at the second administrative level, at the level of district sanitary and epidemiological stations, these reports were used for individual accountability, but it was limited by this scale. We also had to review the legal framework, which was obsolete. They were dated by 1987. In 2002, we introduced methodological guidelines, where we first indicated that adults aged 23 to 25 years old was considered as the study group, and the criteria of well-being was 10 to 30% of serum-negative people. For epidemiological monitoring, the ELISA method is recommended. This reaction was substituted by ELISA because it is more elaborated and more state-of-the-art. The legal framework has the following indicator age groups for serological for serum monitoring. They were modified It last happened in 2011. These changes corresponded to the changes in epidemiological process of measles. Comprehensive analysis of morbidity based on the epidemiological reports and monthly reports allowed us to document the shift in morbidity. And there were more people who were adults, aged 18 to 35, and they were not immunized, they were not vaccinated, which resulted in the activities we undertook in 2004, 2006. We conducted immunization in people aged 18 to 35 who were not vaccinated. Since 2007, this age group has been included in the national schedule of vaccination. The people who were not vaccinated and who did not have a history of measles were vaccinated. We followed the two-dose strategy of immunization, which is very effective according to the global experience. Also, in 2007, we launched vaccination on epidemiological parameters or measles for adults without any age limitations. All these events allowed us to significantly increase the population immunity with the vaccinated people. Individual consideration of cases expanded our opportunities in terms of understanding the crux of the changes taking place in the epidemiological process. We managed to characterize each case and to carry out epidemiological research, which allowed us to set the chains of transmission. And this secondary transmission was truly time-consuming in the territory. And it also indirectly provided to us with the information of the condition of the population immunity. At a certain territory of our country, we assessed the places where focus occurred and also the professional structure profile of the infected people. Since 2012, we have introduced the individual consideration of Rubella cases. The integration of surveillance over Rubella took place in the existing system of epidemiological survey over measles. It's for good, but this individual consideration set new goals for us, and it conditions the need of inclusion of the specialized computer software, which would allow us to process a lot of data. I do not only mean the confirmed cases of measles and rubella, but also the cancelled cases. This program was devised in 2006. Then it was elaborated in 2019. We could see the final version, and now it is represented on this slide. Also, this program enables us to form the reports for the WHO offices. The parameters of selecting the information for analysis look this way. And this list was also elaborated. We added new components in it. One of them is epidemiological classification of the cases. The WHO put forth this classification, the local cases or the displaced cases from the territory, and we were not satisfied with it, and we added new cases in this classification. We added the cases which were imported from other territories but within the country. This classification is a little bit simplified, but it did not reflect the real cases and the real processes. They are well represented in the territories which were supervised by Rostov Regional Center. In 2014, we registered imported cases of measles. You can see the red arrows. The arrows represent the cases. And they were also substantiated by local displacement and migration of the population. You can see the black arrows. And women, the gypsy population. Thanks to this information, we paid special attention to the changes in the social and professional profile of the patients, which signify the priority. We started monitoring the vaccination in hard-to-reach groups of the population, such as members of religious communities, compelled migrants, displaced migrants, the gypsy population, which is not covered by the system of healthcare, and migrants. We developed and put forth the indicators of quality of epidemiological surveillance for verification. One of them is the indicator of excluded cases. There are at least two of them for 100,000 people. Nowadays, two kinds of surveillance function successfully in the RF. There we can see the routine surveillance with specific diseases such as measles and rubella with typical symptoms and signs. And there is also active surveillance in place based on the syndrome. Active surveillance was introduced in 2007, and its quantitative parameter per 100,000 people was elaborated in the course of the pilot project in 2005-2006. This enables us to assess the cancelled cases thanks to two kinds of surveillance. Our indicators exceeded the criteria on an annual basis in our country. I mean the criteria of quality and epidemiological surveillance. We maintained the sensitivity of epidemiological surveillance by tactics of laboratory examination. All the negative serums were titered for IgM antibodies to measles virus, and the negative cases for measles were titered for rubella. Back in 2020, we faced some challenges due to the COVID-19 pandemic. Still, we managed to retain this parameter of sensitivity of the epidemiological surveillance. We could not register the morbidity since June. Thus, the examination of the patients with these diseases still took place, and we accentuated administrative resources. I mean, active surveillance. The patients were examined, and even the patients who suffered from COVID-19 were examined. We did not detect any positive measles cases in this category of patients. The analysis of imported cases showed the clear trend to prevalence to prevailing cases of importation from the countries of former USSR republics. It's over 50% regardless of the absolute figures. Their numbers hesitated from 27 to 132 cases. Still, you can see the proportions. And they were always over 50%. The results of molecular and genetical typization allowed us to identify the genotypes and subtypes of measles virus which circulated in a short-term period in our country, and we had never faced them before. This allowed us to think that the infection had been imported. Epidemiological situation always had some leaders among the countries. In 2019, most cases were imported from Ukraine, where the measles outbreak was registered, but in 2020 the priorities changed, and most imported cases took place in Uzbekistan. In the epidemiological period of 2019-2020, the outbreak was registered. Thus, to sum up, let me mention that Russia has effective epidemiological surveillance over measles and rubella. It allows us to get comprehensive information on time. We have borders with 18 countries. We have intensive economic, trade, and cultural links. This substantiates the dependence of the epidemiological situation in our country on epidemiological well-being. In terms of measles and rubella in neighboring countries, the predominance of imported cases in former USSR republics confirms the presence of this dependence. The detection of the genetic alliance of the strains of measles, which we have never faced before, allows us to think that we have missed some cases of imported infections. Another far-reaching goal of elaboration of epidemiological survey over infections at the stage of elimination is systemic interaction between the services of sanitary and epidemiological well-being of member states of the CIS for make people be informed of measles outbreak and it is also used for preventing the infections. And thank you, Olga.
Интересный доклад предоставили нам всем.
You had a very good presentation. Thank you. That your R&D institution is contributing much into the list of Eurosec and Sanitary Epidemiological Service research, and indeed the retrospective programs to be studied make it possible to have the proper epidemiological decisions. Measles identifies itself pretty often. It is some kind of an imported infection, but always we have to be in the state of alert. Olga Ivanova, the senior fellow at the Chumakov's Federal R&D Center, and she's going to develop on the contribution of the Russian Federation for maintaining polio-free status of the European region. Alexandr, thank you so much. I cannot download my presentation, and I cannot use the clicker properly. Okay. Dear colleagues, poliomyelitis is one of the most ancient infectious diseases, and it entails the paralytic status, a very social, very tragic social phenomenon, and it is a very heavy social load for the society at large. And the high epidemiological situation for that disease has been witnessed on the threshold of 19th and 20th century. And therefore, it has become an impetus for the R&D regarding the vaccines and also using the polio virus vaccine and those achievements allowed in 1988 to declare the global initiative on the eradication of poliomyelitis. Yeah, that's it. Thank you. Thank you for your help. At this point of time, some prerequisites were formed in order to activate the program for combating polio and eradication of other diseases. And already we had some indicator for technical capabilities to eradicate polio. And in 120 countries of the world, we had 350 cases of polio initiated by the wild poliovirus. And we have to be based on the state-of-the-art concept for eradication of this disease. And nowadays, we have the strategic program of that sort, the vaccination for 95% of children, and also surveillance over the paralytic status and the treatment. And so we have been involved in the examination of the acute and moderate diseases, and we had 123 accredited labs, regional reference labs 16, specialized reference laboratory 7, and actually all tests are being conducted with regard to polio. What is the situation with the elimination of polio in the newly independent states from 91 to 95? And the majority of cases related to the wild polio virus had been registered at the domain of the newly independent states, or CIS countries. And the Russian Federation had the outburst of polio in Chechnya and in Ingushetia, encompassing 146 cases. The Russian Federation has a national program for elimination of poliomyelitis, and it was done at the level of epidemiologists, clinicists, virusologists, and the managers of the healthcare system. And this program is based on the various pillars. That is the methodological legal regulatory framework, international cooperation as of 1996-2006, and we are a part of the global initiative for the eradication of poliomyelitis, and also the lab network, which was set up at the level of the Russian Federation, encompassing 6 subnational, 7 national labs, and on the basis of the national lab in the center of Chumakov, we have the regional one, specifically for poliomyelitis. And with due regard to the implementation of the action plan, the indicators for planned immunization were presented at a higher level, and also the surveillance procedure was deployed, and while the polioviruses were not detected further. And the Russian Federation, as well as other countries of the Central Asia and Mediterranean, took part in the unprecedented operation named Megacar and Megacar Plus. And the cornerstone idea of this operation is to synchronize the vaccination campaigns in 18 countries and territories of the Mediterranean and the European part. More than 105 million children were vaccinated, and as a result, by the 21st of June 2002, the European region was registered by WHO as a polio-free region. And what are those follow-up periods for the polio free status maintenance? And it has to be done upon the certification. And within a certain period of time, the immunization is maintained at a very high level, high indication of surveillance level, is in tune with the recommendations of WHO. Also, we provide the survey, the research of the effluent waters, and also we examine the displaced persons and migrants. And in 2008, the national calendar has 2 doses of this virus vaccine embedded, and we started using the bivalent oral medication. And the Chumakov Center has regional labs as well under the auspices of WHO, and such cooperation contributes a lot onto the high level of sustainability of this polio-free status. And as of 2003, the regional reference laboratories surveyed the materials from more than 6,000 cases of paralytic outcomes, and that was fully we were fully in charge of this survey, and quite a number of supplementary materials were collected within the framework of this surveillance idea politics, and some were self-isolated as a result of such examination. The program of eradication of poliomyelitis is a very long-term one, and under the auspices of WHO. And in the course of its implementation and following some complications, we've managed to achieve quite marked success. And in 5 regions out of 6, we have been witnessing the complete eradication of polio virus of the wild nature. And that activity has been certified. And the global program has come across some certain complications, and that is the polio viral vaccine and strain of the disease. And at the global level, the type 2 poliovirus has become a problem. And upon the recommendation of the Committee on the Sanitary and Hygienic Rules, just announced that some emergency situation may occur. relatively to the polio virus. And as you see in here, over the past few years, probably starting from 2016, this polioviruses started to disseminate it all over the African continent. And we witness also here the combined polioviruses dissemination in Pakistan. What kind of risks we are looming large over? And for these countries, we do remember the outbreak of poliomyelitis in Tajikistan in 2010, and poliovirus number 1 was imported to adjacent countries from India, and more than 460 cases of the paralytic poliomyelitis were identified. And actually, we have vaccine-associated polio and also poliovirus of the vaccine origination. And we discussed it at our sessions, and Tajikistan already come across the problem of two-type poliovirus, which comes from the Afghan and Pakistan cluster. And this virus was detected as a result of the acute and moderate cases. And COVID-19 pandemic resulted onto the vaccination scale of poliomyelitis. So immunization is the #1 measure. The broad-based coverage is another measure. Safe vaccination, just reaching the remotely located groups, also the efficient vaccination, and the key goal is to have a high level of the collective immunity and also accessibility of vaccination while ensuring a high level of vaccines, and also epidemiological surveillance over the paralytic outcomes, but also we need to enhance some supplementary types of surveillance, as well as HIV-infected persons. There should be some containment for storing the poliovirus. Also, we have to go on the R&D on the polio, and also I haven't come across the origination of the new monovalent vaccine of the second type, and it could be safely administered to curtail the outbreak of polio. And also we have to oppose the anti-vaccine propaganda. And I would like to thank all the followers of this program and all the staff of the Chumakov Center, Rospotrebnadzor, the Federal Center, and the Center for Epidemiology, and the staff of this Moscow State University named after Lomonosov, subnational laboratories on poliomyelitis of the Russian Federation, newly independent states, WHO HQ, WHO Euro, and all the colleagues from the global network for poliomyelitis labs. And indeed, the organizers of this Congress allowed us to get together here, exchange data and exchange views vis-a-vis the epidemiological well-being at the level of our countries. Thank you for your kind attention.
Thank you, Olga. At the end of the session, you have the Q&A, and now we have a chance to make an exception because we'll have the dinner right after the session. There's one question for you about your presentation, Olga. On behalf of our country and the Ministry of Health of the RF of Kyrgyzstan, let me express my gratitude to your team, to your institution, and to you, because your work should be appreciated. We are not satisfied with the situation in the neighboring countries. We have already declared it the territory of Tajikistan, we can see the emergency situation. We launched the campaign aimed at administration of inactivated polio vaccine. The population has a negative attitude to the fact that the authorization of this vaccine-associated strains takes place. We cannot tell the mothers and the population of the country that there is the reason why it is actually authorized. And we can also see Patrick, the WHO representative. Should we maybe develop the guidelines or the communication in the emergency situation? What is your attitude to it? Will you render some technical assistance in this regard? Thank you for your good words. We have been working with Kyrgyzstan for decades. We are happy to assist you. As for technical assistance, we face the problem of poliovirus, of vaccine-originated poliovirus. Then this problem does not affect our region. We did not pay attention to it, but we created the methodological basis in the region. We have special documents on risk assessments and on laboratory examinations. If you need some assistance, don't hesitate to address us or to Rospotrebnadzor. We will provide you with the necessary assistance so that you could be ready to combat this situation. Thank you very much. Thank you. Thank you for your contentful presentation. Polio is the infection which we managed to combat, and we practically eliminated it. Still, if we stop carrying out vaccination, we can see that the situation may be aggravated, and our work could be considered as futile. Thank you very much. Now, let me give the floor to the head of the Republican Center of Immune Prevention. Immunization during COVID-19 in the Republic of Kyrgyzstan, Gulbara Ishinyapsova, who is the director of the Republican Center of Immune Prevention. We've already touched upon the planned immunization, and you all share your working experience in the situation when the epidemiological situation is not favorable. Thank you very much, dear colleagues. Let me thank all the participants, and let me thank our colleagues from the RF. The immunization issues allowed us to discuss it jointly. This issue is really topical. Let me present to you some information on COVID-19 and impact on planned immunization in Kyrgyzstan. Let me highlight that the country respects all the global goals aimed at polio elimination and the measles elimination in the European region. We're also guided by the European Action Plan on vaccination. Our 5-year programs were completed successfully. There were 5 programs of immunoprophylaxis. The next slide is the following. We updated the policy and reviewed the priorities of the system of healthcare during COVID-19 pandemic. It was the priority of the healthcare system. In 2020, it had a negative impact and created a risk for immunization program on the whole, because the potential of the WHO and medical personnel providing immunization had to undertake the response measures while combating COVID-19. During the COVID-19 pandemic, since March 23rd until March 26th, we suspended planned routine immunization in order to stabilize the epidemiological situation related to coronavirus infection. The vaccination of newborn babies in the organizations of delivery care was not interrupted. It was emergency prevention against the measles of contact people, and then it was planned immunization was suspended for 2 months. We undertook strategical planning, and it included special measures of response in the conditions of COVID-19 pandemic, and then the Ministry of Health decided to renew planned immunization and to accelerate it, as well as to provide medical and sanitary services. Currently, immunization still takes place in the organizations of healthcare, which provide immunization services. We use strategies of vaccination sessions in outpatient care, and we also involve mobile units. We use Gavi means while impacting COVID-19. We reprogrammed these means, and then they were sent to the events, to the activities aimed at decreasing the outbreak of morbidity of COVID-19. And we also decided to decrease the negative impact of planned immunization in compliance with the national plan of the international and intersectoral coordination and the readiness to respond to COVID-19. Mobile brigades were involved in this process. First aid kits and PPE were delivered. The UNICEF means were used for equipping the vaccination points. Sorry, can you see the presentation? Thank you. Now we'll touch upon the coverage with preventive vaccination. The monitoring of coverage with preventive vaccination, epidemiological surveillance over vaccine-preventable infections allowed us to conclude the following. In the pandemic, the primary vaccination complex decreased by 13% compared to the results of 2019. Over 21,000 children were not vaccinated. The children aged under 1 year old. And over 22,000 children were not vaccinated against measles. There is also a risk of infection progressions. It may be prevented by vaccine prevention, and outbreaks may occur. The inequality aggravated, gender inequality, and the risk of the condition of the impoverished population also increased. The coverage with the primary vaccination complex can be seen here. The results are presented for 2015, 2020. We can see the decline in the results for 2020. We can see the Penta 3 coverage at the subnational level compared to 2019, 2020. Here, mapping is represented, as well as the areas which we divided. These areas are the following. 90% account for the red color, and we also have the yellow zones, 90 to 94%. And our indicator implies that our country should reach at least 95% in such regions. And the highest risk occurs in Bishkek, as well as in Chuyska region. It is up to 1 million of the population. And the risk population is related to Penta 3 indicator. You can also see that KPK1 is not in the critical situation because the outbreak of 2018-2019 allowed us to enhance the epidemiological precautions for medical workers. We have completed this work, which is much higher than Penta 3. Epidemiological surveillance and morbidity are represented here. We focus on the impact of COVID-19 on epidemiological surveillance. We did our utmost to respond to the situation with COVID-19, and the lockdown measures decreased the registration of vaccine-preventable infections, and morbidity of parotitis decreased by 11% compared to 2019. Over January-December 2020, 733 measles cases have been registered. Since June 2020, no one has registered measles on all the territories of the Republic. Since week 49, 2020, we have registered these cases in Chelyabinsk and Sugutskaya regions. We can see the retrospective analysis for 3 years. You can see the outbreak, which occurred at the end of 2017. They were imported from Moscow, from the RF. The strain was genotype. Here we can see the cases till July 2020. We also carried out the outperforming immunization. We used the WHO tools, the guidelines aimed at attenuation of negative impact of COVID-19 on combating the disease. Diseases which are vaccine preventable. There are also guidelines on routine immunization during the COVID-19 in the European region. We also have devised the national plan aimed at immunization in accordance with the WHO guidance. Here you can see the contribution of mobile units to planned immunization. They were used during the outperforming immunization. You can see the proportions. There were 4 rounds or even 6 rounds in 2020, and we received these results in these mobile units. You can see the contribution of the mobile units. Over the whole territory, we have involved 64 mobile units. There were over 155 cases of vaccination, and 87.6% accounted for children of under 16 in this region, which was involved in the process. And the contribution of the mobile units was observed in Osh and Sukolskaya region. Now we move on to demand and communication. It is of prime importance nowadays. The demand for immunization services during the COVID-19 pandemic decreased because people did not trust the vaccination because of rumors or incorrect information, and transport communications were also limited during the lockdown. Currently, public communications associated with COVID-19 undermines trust to the system of healthcare, and it also depreciates the vaccine against COVID-19 and questions other vaccines in the framework of our expanded vaccination program. People have doubts on safety, on quality. People dwell upon chipping, and this affects our population. It is of prime importance to raise the awareness of trust in vaccination in our population. We have elaborated our website about vaccination. There were over 400,000 followers, and our university provides technical assistance. It may be included in the list of reliable services on immunization, and now we are working on it. And we also enhance trust. We have been supporting the WHO initiative on the European Week of Immunization. We also organized hotlines on this website so that the population could receive reliable information. Now we move on to vaccine delivery. There was no deficit, there was no shortage of vaccines in the COVID-19 era. It is provided by the UNICEF delivery department. We face some risks. You are aware of the political situation in our country, you're aware of the revolutions and the changes in the government. It negatively affects budgetary funding and co-funding. But let me highlight that we do not have any debt nowadays. Here we can see the mobile session on how to reach population in terms of geographical and social priorities. And this hard to reach population is achieved by us. We also engage the Red Cross volunteers. It is needed for both vaccination and for carrying out questionnaires. It allows us to share the information which is crucial to our population. I changed my presentation a little bit. That is why I was a little bit anxious. Mobile clinics were also involved thanks to the RF efforts. In January, March 2021, we engaged mobile clinics within the project. We were involved in 5 regions. Bruratál is the most active one. We have covered over 3,000 people with these mobile units, and we will keep working on it. All our resources and our expenditure were implemented via the WHO. Here you can see the link to our website. It is available to everyone. It is really interesting. We receive good feedback. Here you can see my grandson and my daughter, and they came to vaccination, and I took a photo, and you can see this photo on the website. I wish you great success. Hopefully we should start everything with prevention. I mean, vaccine prevention. Despite the pandemic, as Anna has already mentioned, we shouldn't forget about other infections which come back, which remind us of themselves. They're even more hazardous than our novel coronavirus. Let me once again express my gratitude to our colleagues from the institution of Krzyzewski, because your contribution is great. We have been working within this project aimed at elimination in Middle Asia. Hopefully we will be able to keep working on these projects. Our Center of Prevention will fulfill all the obligations. The RF is our key partner. Thank you very much.
Thank you, Gulbara Sakhtegulovna. Actually, Gulbara was our last speaker, so I suggest to put the questions from the audience, or Olga Valentinovna will put her questions, and within the coming 10 minutes, we may comment, put all sorts of questions further. Thank you very much, Gulmara. Thank you for your very good words addressed to us, and more than 200,000 children were not covered by the vaccination. But you talked about mobile teams, and did you manage to identify non-vaccinated children over 1 year old? That's my first question. And my second question is that you've mentioned the vaccination in the hotspots for measles. What about the legal regulatory framework? Does it fit into this particular framework, and what is the current status for vaccination? As to mobile teams, I would like to say about their weighty contribution onto the vaccination process, and they used the entire potential of those mobile clinics. And I took into account February, and now we have some kind of a catch-up companies, follow-up companies, and that was all organized by our stat committee. But now, I guess that this percentage will be about 13 originally, but now it's 8% for children. We covered the majority of those originally are not covered. And some statistics arrives later, by the end of April. And as to some kind of a follow-up companies, we suggested some urgent vaccination, and we never stopped the vaccination. That was mono vaccine for measles. And nowadays, we use 50,000 altogether, and that was all decided by the regional headquarters. And no longer we have a quarantine. In the Republic, it has been lifted, and the vaccination is fully accessible in the hotspots of diseases. This follow-up vaccination is not a characteristic for Kyrgyzstan. It is a problem for all the republics. Thank you, Gulbara Sultagulovna, for sharing expertise of your own. Probably we have other findings to remind and discuss. Any questions in the audience? Maybe someone would like to write from the studio, from the online. By that, we terminate our session and declare the break. And I would like to thank all the panelists of this session dedicated to the controlled infections and vaccination. Thank you for your weighty contribution. I wish you all the best and very successful and fruitful deliberations for the sake of our population and our countries as a whole.